joining and attending the conference regarding COVID-19. And I would like to appreciate all in IT Jackson to put together and making this happen. David Lacerda did excellent job as well. So let's start with respecting. Let me finish, close my video, and then we can talk on the slides. I want to start with special respect to those who fought with COVID-19 and lost their lives. We have Dr. Lee, that was the first physician noticed abnormal activity on people in Wuhan General Hospital and reported his life with this disease, and also all doctors in China, in Italy, in other countries, and also nurses that I tried to put one nurse from Iran that lost her life because of COVID-19. So let's start with a clinical update. Today, what we're gonna do, we're gonna talk about science behind of COVID-19, what we have and what we know, and definitely we're gonna touch different parts of epidemiology, clinical treatment, and also outcome and prognosis for COVID-19 in our country. Learning objective, hopefully end of this 1 hour talk, you will be able to describe current epidemiology of COVID-19, describe clinical presentation and diagnosis of COVID-19, and describe treatment strategies for COVID-19. I don't have any conflict of interest with this presentation. I've been awarded from Mallinckrodt for sarcoidosis research before. What we have and what we know about this novel coronavirus. We know that this RNA virus is a large envelope virus, and also we know that almost 10 to 30% of upper respiratory tract infections in human caused by coronaviruses. So this is not really novel virus in the family. Since 1960s, we know coronavirus. However, we had 3 major change in coronavirus family. One was SARS coronavirus, another one MERS coronavirus, and now COVID-19 that caused significant and severe human infection. And for many of those, we are thinking that animals are a resource, and maybe this is something that we can, for future, work more on understanding better. This is electron microscopy for coronavirus, and you can see that spikes around that we call S, and these spikes make this special crown shape that named this virus as coronavirus. If we compare coronavirus and with other diseases in the same family, and also with flu, I have good information for you regarding the basic reproductive number for flu is 1.3, for COVID-19 at least 2.2 to 2.5, although we're going to talk about this later on. SARS was 3, and MERS definitely less than COVID-19 and also SARS. And then if you look at for hospitalization rate for flu, we have only 2%, but now we are talking, and that is COVID-19 that make big difference for hospitalization rate, and SARS most of the cases, and MERS as well most of the cases. Another very important is case fatality rate, that for flu is 0.05 to 0.1%, but COVID-19 is in the range at least 2 or 3, but we're going to talk that may go up. And for SARS was much higher, and MERS got 34% mortality. And we're going to talk about annual and global incidence rate later on, and we're going to go from there. This is the data that I got from CDC. Before moving forward, I want to just emphasize again and what type of infection we need to control epidemics and pandemic at this point. Evidence that we need number of cases, including even mild cases. We need to understand risk factors and timing of transmission. We need to understand severity and attack rate. We need to understand the severity pyramid that we're going to discuss about this. We're going to talk about risk factors and infection and severe outcome, including death. And we should understand infectiousness timing and intensity for each single one. As you know, that COVID-19 been announced or declared by World Health Organization, WHO, on January 30, 2020, as a public health emergency. And that was the first time people from China reported good number of cases. And around the world, any study started to be done. And that was a time that as an average, people talking about that infected individual caused 2.68 additional individuals infected with this virus. Transmission so far we know is droplet. We know that fecal oral being proposed recently, very recent, airborne was another concern. At this point, we are not sure fecal oral and airborne are major route for transmission, but definitely droplet is the major transmission route for COVID-19. This is, I pull it up for data for today and literally 2 hours ago, and you can see data for Florida. We have 328 cases and 299 cases from Florida, and we have 29 cases non-Florida residents, and more than 900 people right now monitor. We have very big number of people that are pending for the test, and that's probably going to increase the number for total cases in the following days. Regarding in the world, you can see here that is moving so fast. Right now, we have plus 200,000 confirmed cases around the world, and more than 159 countries reported COVID-19. At this point, more than 9,000 people died with this infection, and almost 84,000 reported as recovered. If you look at for this part, I'm trying to highlight for you, the last number for United States is 9,415 cases. That is very fast growth rate in the last week, and that gonna be the pattern, and we think that very soon that's gonna increase in the number of other countries that we have in the top of this list. I want to emphasize for this is very important fundamentally understanding about what's the meaning are and what's the meaning that curve that everyone talks about that. Whenever that you are talking about every epidemics, you need to talk about two numbers, basically basic reproduction number or effective reproduction number as R, if that is right now in big epidemics or pandemic. And entire aim for all operation is making this RO less than 1, because if that happen, means that epidemics that you are facing with, regardless of type of infection, gonna burn out. And if that stay in the range of 1, epidemic will continue at a steady pace. And the worst case is whenever that you have R more than 1. And that is the time that epidemics quickly gonna increase and get big number of people. And just a little bit understanding about that R, how we calculate the R. R is calculated based off this equation. And this K, that constant K, is logarithmic number of growth of number of cases in one specific community. For example, we have 50, and then tomorrow we have 100, then we have 1,000, then we have 10,000. This is gonna be logarithmic of this number we're gonna use as a growth constant in this equation. Another two magic number here is L, that is average latent period. Every infection does have a latent period before getting clinically symptomatic. For the people that getting COVID-19, being discussed about 4 days to 14 days, but as average 7 days, maybe this is whatever that we can accept. And D as an average infectious period means that whenever that you got this infection, how many days you can pass this infection to others. As you noted in this equation, only way that we can get R or RO less than 1 means that first part of this should be negative. And the only way is we can decrease the number for the dose, then the growth rate gonna decrease, and that gonna make negative for you. Then entire this part of equation will be negative. And I put two other papers that discussing more. If you are interested, you can see that two reports, particularly this paper, gonna tell you about how we can get R calculated. And this is a report that we had from Washington State Department regarding how that time they were thinking about RO and understanding that how that would be. And they find it out up to 4, maybe that is what they are thinking, and that should be discussed. Then if we want to get R less than 1, what we need to do and how many options we have and what are our options. One thing that's important is we need to decrease D, means that duration for infectiousness less than 2.3 days. And this is really, really the only thing you can change in your equation. How we need to do it. And that means self-isolation. That means that no contact between people. And that means that as soon as that we find a patient, as soon as that we know that you are exposed, you need to make yourself isolated. And that's gonna decrease the change. If we can make it at 2.3, then we can stop epidemics in any community. And second option that is very wild type, or maybe that is natural history of disease, is the COVID-19 virus get stability in community. And this is people called as herd immunity. If that happens, means that at least should be 50 to 70% of population infected with this virus. And after that, that's gonna stop and turn down epidemics with COVID-19. Some countries, unfortunately, they are heading to that direction. And they want to have 60% of the population infected and try to control COVID-19. We're gonna talk about this, that what is the downside for going to the second option. Another point that I want to make here is we learn from cruise ship and that R is very different based off the community that you are calculating that. In cruise that we had a couple of those epidemics in the last month, we learned that R maybe is 15, means that one patient in very close environment can involve up to 15 other people, and that very quickly get majority of people involved. So that is the base that you're gonna think that we need to do restriction in the cities, or that's gonna be restriction for the country, or we are not going for restriction if you are going for the plan B, that is reach to stability. Here I put some models for you. In the first model that you can see, they are talk about R1, that is STD infection and continuation. But if we do good social distancing and try to control infection in first place, that's gonna happen. Our curve gradually gonna decrease and we're gonna pass one. In that case, we can control epidemics. And some communities, I think that Italy reaching that point, that reaching to saturation. They are doing a good job, but whenever that reaching to entire our, their infrastructure, then the number gonna increase again. And this is for the communities that they are not controlling, and that's gonna increase very fast and quickly the number of people. This is very nice data regarding how many patients based on the logarithmic of 10 going to increase after 100 in different countries. And you can see here, Italy and Iran, they have the highest number because of very poor control or late response. And then other countries like Hong Kong and Singapore, they are very low and they are trying to control it very well compared to others, and we are kind of middle. Although this number significantly is increasing, and right now we are more than France and very close to Spain. And why is different with flu and seasonal flu? If you have rates are of rate 1.3, 5 cases, and after 5 cycles, you're going to have 45 patients. But if you look at that for COVID-19 with average rate of 2.6, that really is not the earliest stage for epidemics, that much higher than this, you're going to have in 5 cycles 368 patients. And that is a reason patients with COVID-19 and so in. This is a number for flu, and that is by CDC that for seasonal flu, we're gonna have 32 million to 45 million illness each year, and that is basically for this cycle. And then 14 to 21 million medical visits, and almost 310 to 560,000 hospitalization, and death, unfortunately, in the range of 18 to 46,000. However, if we calculated this based on the COVID-19 with facts that we have are almost double, that's going to be predicted number, that very optimistic way we calculated. That is 64 million to 90 million illness. We are talking about 28 to 42 million medical visits, 620 to 1.120 hospitalization, and 36 to 92,000 deaths. However, my prediction was very optimistic. This is prediction for American Hospital Association, and this is what for that they are putting together as the best guess epidemiology. And the number, if you can see here, significantly higher in the different term. We are talking about 1.9 million ICU admission and 480 deaths. That is more than 4 times that we calculated based on the best optimistic model that we had here. And basically, this is what for that happened. For many states, we have hundreds and hundreds of those patients, and that is the reason very quickly we reached to almost 10,000 patients. And this is another very important point for all of us that we need to understand it, that why we need to limit exposure for people, why we need to do it. The curve here, whenever that you have purple, is much higher in earlier stage if we are not controlling. And this is our capacity, how we can take care of people in the United States. And if we can decrease the purple reaching under this, we can decrease mortality and we can decrease damage to our community. And if we want to do it, how we can do this? I put here a part of a statement for Society of Critical Care Medicine. And at this point, looks like that the total number of ICUs that we can provide in the same time in entire nation is 200,000 units. But based on the calculation from American Hospital Association, we may need 960,000 beds to respond to this epidemics. So this first thing should give us the idea. We need to slow down epidemics, and then probably we can respond well. Having said, I put all information for the number of the beds in the United States and other countries. You can see compared to Italy, we have almost 3 times higher number of ICU beds. And that is still going to give us this big difference between 200,000 to almost 1 million beds requirements. And this is calculation that Harvard team did recently, and finding out if we have 20% of patients that getting into our hospitals based on the number of people that there are there, and gradually the number increase. If we get 60% of community involved over 6 months, this is what for that we have, and this is significant involvement in all states, all hospitals saturated based on the capacity, and I'm talking about twice the number of beds in each hospital, and unfortunately with 60%, we're gonna be paralyzed for the next 6 months. So only way that we can break all prediction that I discussed so far is asking people staying home. Collaboration with people is the most important key for entire process that we are discussing at this point. I want to talk a little bit about virus for you. And what's happening for the virus here is this virus has been changed for a couple of places in spike 1 and 2, and that's gonna be difference between other viruses in the same family. And now we are learning what part of this virus change, and maybe that's gonna help us to develop good vaccines to control it. This is another study, although very challenging. A couple of papers try to reanalyze this data and saying that might be other results should discuss from this result. However, at this point, we are thinking that there are some mutations happening, and number of mutations may be increased gradually. For coronavirus, we know that this virus usually doesn't like to have a lot of mutation, and is very different with flu. But there is a risk that mutation happen, and depending on what location is, maybe the effect for vaccine gonna be very challenging. Regarding animal resource and talk about receptors, I put for you here COVID-19 is linked to ACE2, angioconverting enzyme 2, that we're going to talk a little bit. SARS virus had the same, and SARS coronavirus like that had the same thing that we're going to discuss about that a little bit later. So pathogenesis, we need to understand that this receptor exists in lung pneumocytes type 2, GI epithelial cells, brain CNS, cardiac, and vascular. Those are major at this point. Very, very, very new data. Just a couple of days before, I read that ACE2 was found in nasal epithelium too. And if that is the case, maybe that's gonna be another resource for entering virus. But basically what happened is this virus and S, that those green parts are gonna attach to this receptor and gonna get inside inflammation, and after that deliver those inflammatory response to the blood and getting of the body. ACE2 receptor does have good number of mutations, and those mutations may be related to different ethnicity. But at this point, we don't have good data regarding mutations and also ethnicity association with COVID-19. Case definition is very important. At this point, you know that multiple times CDC changed this definition, but basically every patient with fever and severe acute lower respiratory illness, including pneumonia, ARDS, and requiring to the hospitals without any alternative diagnosis like flu being called as a case, and that even without any source should be tested. There is new data, very new data, that been challenging and talking that maybe 20% of people with COVID-19, they had co-infection with other viruses. Still, I don't know how much we need to change our plan and practice at this point. CDC has not changed anything in definition yet, but we should consider that at maybe a case for COVID-19 too. The disease, but it does have two specific phases. Phase one is first week. In first week, people, they're gonna have fever, shortness of breath a little bit, chills, and general common cold presentation. I'm gonna talk about symptoms a little bit later. I'm gonna discuss about what we're gonna see in this phase. But in second phase is the phase that respiratory problems will be the dominant symptoms, shortness of breath, respiratory rate increase, and then those people needs hospital care in different level and maybe ICU care. One thing is important in this disease is we should understand two different phases. If your pain is improving in a couple of days, doesn't mean it's not going to end up respiratory failure. And I want to make sure that everyone understands this risk, significant risk, a little bit improvement, then after that, poor condition in the lung, ARDS, and death. In general, what were we learned from China? And now some twist on it that I'm going to talk about, but talk about mild disease in 80% of people infected with COVID-19. Recently from Italy, we are learning that that 80% probably is not 80%, maybe is 65 to 70%. But anyway, good number of people that they get this infection, they're gonna get mild disease. And severe disease happen in almost 20%, that those people, they have O2 saturation less than 90% in room air. Please pay attention to this number. Every patient suspected COVID-19 that O2 saturation is less than 93% in room air, you need to consider as a severe disease. And people that hypoxemia require non-invasive and invasive mechanical ventilation, they have shock and organ failure, we call critical case, and they should be admitted in the ICUs. And depends on different hospital, different policy, the location may change later on, and policy will be revised in any center. 3%, 4%, or 6%. Depends on what condition we are talking about, death rates will be reported. However, for the people that end up to ICU, has been reported that 50% may die. And majority of those new cases we are learning from Seattle, they may end up to cardiomyopathy. And cardiomyopathy, all of a sudden, ejection fraction decrease to less than 10%, and patient is not responsive to any type of treatment, including procedures that after cardiac arrest happen, and many of them die with their symptoms. Still, we are learning about cardiomyopathy in COVID-19, but looks like at least in the setting that we have good ICU care for patients, that is a major driver for death. For age of people, this has been discussed in many settings. This is not true that kids are not be infected. That is not right at all. There is a risk, almost 1% for the age of 0 to 14 years, and that should be a strongly a concern, and we should understand that. Between age of 15 to 49, we had good number of patients, and you can see the number around 50% of people involved in that specific age. I try to show you about fever. For the people that first time you're gonna see, the high fever was not a major report here. It's 3.5 or 3%, less than 5%. But whenever that they are hospitalized, the rate increased to 11 to 12% of patients infected with COVID-19. Cough is very common finding, and also some of them will be a productive cough. Doesn't mean that all COVID-19 should be dry cough. And here in this report, you can see that people with coexisting disorders being found very slow and low number of the cases. For severe people, find it out in 21%, and for non-severe in 23%. And that is the range that you can find. So that is alarming. Many of people that will be seen by you, they have no coexisting disorders, and we should be very careful about healthy people with respiratory symptoms. You can see that COPD report, what were they reported in China was 1.1, and with severe less than 1% of patients. And whenever you are talking about laboratory finding, lymphocytopenia is the major finding that in CBC, whenever patient admitted, you can see it. And if you have any patient that white blood cells shows cytopenia in general and lymphocytopenia specifically, we should be concerned. And magic number maybe 1,000 is considered for it. And for less than 1,500, more than 80% of people, they have in that specific range. CRP is another simple test that good number of people, they have high number of CRP, and we are talking about more than 10. This is almost 50% of patients. So please consider that CRP and lymphocytopenia will not exclude the diagnosis. But if they are high, maybe they are important for prognosis. And here I try to compare 3 studies in Lancet and also New England Journal that right now I show you that what is the percentage for different conditions, fever in some of those in 80s, and you can see that headache is something happen in some people, myalgia in 15%, that is the range being reported, and other factors that you can see here. This is a slide that I want all of you to take a picture, a little bit understand it. Again, this is clinical finding, doesn't mean that cause a way that you can differentiate significantly, but we can say that usually for COVID-19, you don't have high temperature. And this is flu that does have very high temperature in the first place before getting in the hospital. And whenever you look at for others, chills is very common and severe in flu, but in COVID-19 is not very significant finding. If you remember, that was around 16% of population. Headaches is very high, common in flu, but is not that common in COVID-19. Cough, as we discussed, 60% commonly is dry. Runny nose, very rare for COVID-19, but very common in common cold. Obviously, that's gonna be one thing that we can see. A sneeze is not significant finding in COVID-19. If you have anyone sneeze, don't freak out. Probably COVID-19 is not the case. Nasal congestion is very unique, that common in COVID-19. And I had one patient told me that he noted the most severe nasal congestion in his entire life. And that was kind of big thing in my head. I don't know, maybe that we can differentiate with flu at least in those patients with COVID-19. Shortness of breath is common and severe. As you know, cold is not going to cause any shortness of breath whenever it's not complicated with pneumonia. Body pain, very common in flu. Nausea, vomiting is more common in flu than in COVID-19, and for common cold, we don't have it. And diarrhea is not really common in common cold, but more common in flu. As we discussed, cardiomyopathy is a big concern in this disease. Is it because of affinity of this virus to ACE2 receptor in heart and myocytes? We don't know. Is it related to the medication that we are using as ACE inhibitor? That is another theory that people talk about. But one thing we know is if a patient is critically ill, the chance for cardiomyopathy significantly increased. And this is another thing that we learn. Those patients that we get in ICU, troponin is a little bit higher compared to others. It's not that significant that call the patient MI, but that might be higher compared to other ICU patients. There is a risk for neuropathy, and that is new paper published and showing that receptors maybe is in brainstem, and that is the reason that sometimes if you do good resuscitation, still you cannot get the patient because the brainstem is infected and stop driving. What we need to do test for testing, as you know, swab is the most important part for this test. However, please make a good nasopharyngeal swab. And if you remember, for getting a good swab, patients supposed to be very uncomfortable for your test. If that happens, means that you are doing a good sampling. Pharyngeal and rectal swab, two other methods. And nowadays we know that rectal swab is positive in almost 50-60% of patients based on the different reports, and maybe that's gonna be so for oral fecal. Although one study from Germany very recently talking virus from rectal swab, all they were dead, and maybe that is not the case. So at this point, we don't know. That's the reason I put question mark for that route of transmission. If patient is intubated, we can get tracheal aspiration. However, bronchoscopy, we would, and please, for all recommendation from Jackson, go in the website and learn what the Jackson protocols are. Generally, bronchoscopy is not recommended for those patients because of very high risk for transmission to other people. COVID-19, we need to do RT-PCR, and looks like that specificity of this test is very high. However, sensitivity is a problem. It's just 60 or 70%, and I believe that one reason for that very low is we are not doing good job for nasopharyngeal swabbing. That higher if we do better job. A single negative RT-PCR is not going to exclude COVID-19. And this is another very important point that hopefully all we should understand that. If you are highly suspicious, you have other evidence, and you are convinced with one negative test, don't accept that that patient doesn't have COVID-19. And here is a number of the cases that so far has been done per 1 million population. You can see that still we are not doing that good job. We are a little bit beyond of what we're showing, but hopefully very soon with the help of commercialized labs that right now they are doing something for us, and other factors and accessibility for the test that is going to happen very soon, the number will increase. The number that we have the highest is South Korea, that they did more than thousands. I'm talking about 220,000 tests has been done for people, and that is basically the highest number ever been done. And for CT scan, people asking about CT scan, please review Jackson protocol. What indication is obviously each hospital based of the resource. We have very limited resource for CT scan. We cannot send everyone, obviously, understand that. But this is type of evidence that we have. And those opacity ground glass that you can see, very typical for COVID-19. Usually you can see preferably of chest, you have ground glass opacity. We are learning that this is kind of very common presentation for COVID-19 in many cases. There is one study published, and in this study, you can see that there are talk about sensitivity over 97%, but specificity is very low, 25, and that makes sense because that opacity usually could be many other type of infections. And right now, this is what we're that around the world, people different type of thing, and I'm very pleased I'm presenting today that we have outside tents, and we are testing people, and this is really the best way to get people out of hospitals and getting in parking lot and other places as much as possible, avoid for exposure between other people. What we are doing for treatment, let's a little bit explain for treatment. What is the goal and a strategic goal for treatment COVID-19? First, all patients with COVID-19 must be identified immediately and isolated prior to causing unrecognized, unprotected exposure. This is most important thing, particularly for hospitalists. And whenever that you have a patient concern, for any reason, you need to activate testing and communicate with people that they are working for COVID-19 unit. Second, transmission of COVID-19 virus to other patients, visitors, and healthcare workers must be never event. That is very important. Recently, we had called conference with Italy, and what we learned in early stage for epidemics, the numbers of doctors being involved with COVID-19 was higher than the other patients. This is very important that everyone should understand and be careful about yourself and other people too. Please review the protocol that Jackson already prepared for the visitors for those patients, and we need to follow a structure-based protocol. And critically ill patient with COVID-19 must receive the best possible care without putting healthcare workers at unacceptable risk. Again, we want to give our best care, but in the same time, we should protect healthcare workers. And those are the strategic goals that all should follow in the entire nation. For medical treatment, there are many studies right now. You can see that good number of clinical trials right now going on, and people looking for different medication. But what we know at this point, let's talk about whatever is available for us. Chloroquine as anti-malaria and amoebiasis medication looks like that does have good efficacy against COVID-19 virus. Basically, it's SARS coronavirus 2. So what is happening here is, looks like that chloroquine block ACE2 receptor and preventing of adhesion the virus to the cell, and that is a way that decreasing damage in the body. What dose? We have different dose. Please review Jackson protocol for that, and that is different doses based off the protocols. I put 2 here, and please review what we have in Jackson for that. Side effects is very important. All we need to learn. 54% blurred vision is a side effect. We should be very careful about eyes for those patients that we're going to prescribe chloroquine for. Pruritus in 22%, that is another very common side effect that we should learn and go from there. I would like to emphasize on it. QT prolongation, is so important for chloroquine. And please, whenever you are giving chloroquine to the patient, make sure if you are using levofloxacin and moxifloxacin, there is higher risk for torsade for the patient that they have QT prolongation. Metoprolol causes the same thing. So please be advised, be aware that we need to check EKG for those patients that we are suspected and we want to give chloroquine. G6PD, we don't have that much G6PD patient in the United States, but we should be aware that people that they have G6PD, they are higher risk for hemolysis and anemia if they are using chloroquine. Kaletra. Kaletra is antivirus that being used a lot for HIV. We know how it works for HIV, but looks like that gonna stop and block replication for coronavirus. This is whatever that we learned from SARS. And after 5 days, you can see that logarithmic copies of SARS significantly decrease in majority of patients. And that is what for base that we have been using Kaletra for a patient with COVID-19. What is the dose? Is 400 milligrams and 100 milligrams BID at least 5 days based on the information that provided here for you, at least 5 days, but in some cases maybe extended to 14 days. Please follow Jackson guidelines for it and protocol that already prepared, and that's gonna give you more information about those that we are using in Jackson. Side effects, let's talk about this. The most common side effects is diarrhea in 14 to 24% and nausea. This is two major side effects that you may deal with it. In lab, you can see that total cholesterol in 27% may increase, and triglyceride up to 26% may increase. Pancreatitis may happen, and new onset diabetes. Those are not really common side effects, but the most thing is GI upset and diarrhea. Although this is a paper that published yesterday, clinical trial published in New England Journal, and using lopinavir and ritonavir, basically Kaletra, for severe COVID-19. And they included almost 100 patients, and they couldn't find really any significant outcome for the people use placebo or use a Kaletra. Even for viral load, as you can see, there is no significant change. Are we going to change our policy? I don't know. This is a big question. Yesterday, everyone asking the same thing, that based on this clinical trial, do we need to stop using Kaletra for COVID-19? At this point, I would say that we need to continue whatever we are doing until get consensus from different locations, and also for UM, we're gonna find it out that what's gonna be the best approach, and we're gonna go from there. That was Tamiflu. People use Tamiflu for COVID-19. But compared to 2-3 weeks ago, we are learning a lot that Tamiflu looks like that is not that much promising for COVID-19. So that is a reason for both UMH and Jackson. I discussed about treatment with our team. I'm not sure that Tamiflu should be a part for any protocol. But again, we need to back to Jackson protocol and review everything, and maybe we need updates on this. A steroid, another big question. People asking that, do we need to use that? So really, we don't know. There is few information on this part. Generally, would not recommend using a steroid just for COVID-19, but if the patient came with asthma and COPD exacerbation, you need to give a steroid, that is fine. You can give for short term, and I think that everyone is fine with that. But most promising medication at this point is remdesivir. Remdesivir is antiviral that first time received FDA approval for Ebola and being used for MERS. And right now, 2 clinical trials is NIH and also company. They are putting this, and that is probably most promising for every patient. In Seattle, in different ICU hospitals, this is the first medication everyone try, and many of patients at this point, they receive remdesivir, and looks like that some good response from remdesivir is out there too. How are you going to get it? Make it a little bit practical for you. There is a website here, I put it, that is for the portal for company. What we need to do is we need to get there and requesting for your specific patient. And whenever you put your request, almost in 30 minutes, 1 hour, you're going to get results. What they accept and how they accept it. Key inclusion criteria at this point is every patient that's hospitalized is on mechanical ventilation and confirmed by PCR. So 3 things should meet, otherwise please don't apply for this. If the patient does have multi-organ failure, if right now on pressors, at least more than 5 times ALT happen, and creatinine is less than 30, and the patient right now on replacement therapy, probably that patient is not a candidate to receive medication. So please do action in early stage. Whenever that patient get intubated, you already have everything. And before getting multi-organ failure, basically because of the liver and kidney, and that is the highest chance for the patient to get medication. There is need for IRB, but at this point, because it's emergency situation, we're gonna request, we're gonna prescribe it, we're gonna give to the patient, but within 5 days, IRB should be involved. And this is something that yesterday we tried to understand it better and move it forward. And in China, they started double lung transplant surgery for a patient with COVID-19. How this gonna work, I'm not sure that's gonna be the biggest at this point, particularly whenever we have overwhelmed the system with COVID-19, but at least that has been discussed. ECMO is another thing. And there is a registry right now, society, and this is another modality. How much we can use it, and this is definitely with Ali, we need to sit and discuss about that. Overwhelming our infrastructure and resources probably is not a good choice, but maybe a very selected patient, very, very selected cases, we can use ECMO and we can save lives with ECMO. But for all of those, we need to back to Jackson protocol and guidelines, and we're gonna follow what were that Jackson guidelines. This is rate for mortality from different countries and projection. I put for you this specific slide for learning one specific things. If a country get overwhelmed, like Italy, mortality may increase to 20%. And that mortality rate is not because of virus around, that is because saturation for healthcare sources that may happen. This is fatality rate and death in different countries, and that was in really what for that early stage was, but gradually that is going up in the countries that are not well controlled, like Delhi and like Iran. And fatality rate in China, because of what for they did, they went down, but basically it's not that 2% they claim first or 3% whatever they said is much higher than whatever that so far everyone claims. So regarding COVID-19 mortality, at this point, this is data for the United States. We have 150 total deaths that you can see here. State Washington does have the highest, New York, and we are unfortunately here in the 4th place, and we have 8 deaths so far. And then for total, we have plus 9,000 deaths. And you can see China still is high, but I think that very soon going to be higher than any country in the world. And other countries that are coming after that. And if you look at just state Washington by itself, we are in these steps. But if we compare entire nation, we're going to be higher than United Kingdom in this list. For mortality, I have one more thing. For mortality, here you can see that age for 0 to 9 for confirmed case, and for death, we don't have any death when we review 44,000 patients from China. And in the age of 10 to 19, one patient died in the 549 cases, and gradually, whenever that age increased, mortality increased. And almost in the 60s to 70 to 69, 30% of the cases died in the range of this group of mortality. So people, whenever they're age, they're gonna die higher. We know that. And younger, they are not dying that fast that compared to other ages. This is very important and very new data too. There is animal study done in monkeys and learning that reinfection can happen in monkey. This is kind of promising. If that data replicates what we have in human, there's a good chance that we can develop good immunity against this virus. That was a big concern. Some case reports from China and from other countries, but looks like that in animal model based after this study, hopefully human develop immunity, and that gonna be very promising data. Home disposition. You will deal with home disposition. Should be coordinated with health local department. That is very important, because if we don't communicate, we don't know how to follow those patients. Patient should be able to have a separate room and bathroom for self-isolation. If everyone living in one room, probably that is not the best option to send the patient for home disposition. Ability to request help. If respiratory situation worsening, supposed to ask for help. And then someone should be there, and if anything worsening, supposed to give a call. And then we need to understand that people living in that house, how risky they are. If they have significant medical comorbidities, maybe that is not going to be a good idea. And who we going to send? Person that at this point, there is no evidence for significant pneumonia, there is no significant chest infiltration, and also there is no hypoxemia. But there is discussion regarding pet isolation. There is some evidence maybe pet be infected too. WHO at this point doesn't have any recommendation for this part. And last thing, 2021, that is the care efficacy for flu in 1918 and 1919. First step in 1918 increased, and then we have another epidemics in 1919 that kill a lot of people too. And that is concern for 2020, that we may have COVID-19 and attack again to 1,000 or maybe millions of people. And in right side, I put another thing. Another concern that all we should understand is our economy will drop in this situation. And if we get low GPD, that's going to significantly increase mortality, and number for people that they're going to die regardless of COVID going to significantly decrease. Number is going to increase and survival going to decrease. So we need to understand the impact in economy, impact in humans, and also epidemics that in next year we may have. We should prepare for it. Prevention, you can see that people getting so crazy, they are doing many different things that really unnecessary and doesn't mean anything. We should call people, ask them, try to postpone community and any gathering stay home as much as possible, follow CDC recommendation, hand washing, mask, and other things that all we discussed should be discussed again. Cruise trips already closed, everything is shut down, and hopefully with all procedures that we are doing, we can control this disease. And for post-exposure prophylaxis, some of you may ask me, at this point, really, we don't know. One clinical trial with chloroquine will be a start with University of Minnesota very soon, but antiviral therapy works or not, nobody knows at this point. And what I would suggest, please share this with your patients. Should we stop, spread germs and COVID-19, we need to do for general precautions that always we recommend to every disease, any patient. And thank you very much.